Hello everyone, my name is David Nguyen. I'm one of the sport medicine residents at the University of Toronto this year. I'm just going to present on my academic project this year titled Mapping Evidence on Facial Protection and Injury in Ice Hockey, a project that's supervised by Dr. David Lawrence. So as a brief introduction, we know that hockey has high rates of head and facial injury. It's common within the sport and can lead to significant morbidity, deformity, time lost from play, and financial loss to teams. Across different leagues, there's various levels of protection in terms of facial coverage, whether it's NHL, NCAA, Ontario University Athletics, and other semi-pro organizations, each having their own set of guidelines towards visor and cage requirements. And oftentimes we see within hockey culture, players' comfort, preferences, traditional values, and perceptions of toughness influencing rapid adoption and timely adaptation of facial protection policies. So let's take a look at a player's path from junior leagues to professional hockey. Someone here in Ontario may play for the Ontario Junior Hockey League, where under Hockey Canada, it's recommended that they wear a full cage. If they attend a university here in Ontario, they are governed by OUA. So here for the Varsity Blues, they're only mandated to wear a half shield. But let's say they move to the United States and play NCAA. Well, there it's back to a full cage requirement, and they'll play that for the rest of their careers unless they go towards a league like the NHL, where once again, we're back to half visor requirement. And across this path, we see different safety standards and policies surrounding this protective equipment, although the overall risk of facial injury doesn't really significantly change. You'll notice that in the NHL, there's fewer athletes going visorless for obvious reasons, and that was really a reactive change by the league in the 2013 season that mandated new players to at least don on a half visor, and some of the players now actively continue to play visorless. So that really inspired the reasoning behind my academic project, which was to investigate what evidence exists on the relationship between facial protection and facial or head injury among ice hockey players across different hockey leagues. I intended the project to be a scoping review, studying ice hockey players across all competitive levels and leagues, exploring the concept of league policy on facial protection and its relationship to the injuries that they succumb to within the context of organized ice hockey settings. Preliminary research reviews several articles that have already elucidated this relationship, and you'll see the oldest one was actually in 1999, studying Canadian university players. And that relationship was already clearly defined back then, but the leagues were quite delayed in picking up the best available evidence. And so across all of these studies, the evidence is quite compelling that protection works, and that full protection is better than half, which is better than none. The relationship with concussion is unclear at this point. However, it does highlight that policies need to change within different hockey leagues to keep up with the available evidence. So what are future directions? After the scoping review that is planned for the next few months, this pivots very nicely into a possible multi-center prospective study across the Ontario University leagues using data from athlete injury and surveillance patterns to try to elucidate that real-world effect of facial protection. More broadly speaking, in the pediatric population, it reinforces principles of primary injury prevention, and it helps to safely facilitate lifelong participation in sport across all levels and ages. Thank you very much.
Does anybody have any questions for David?
There is a situation even in Toronto where one university has one rule and another university has another rule, and that's influenced by the insurance companies. Any thought about including that into your algorithm?
That's a very good point. I hadn't recognized that in my research, but I think that might open up a more broad scope that I wasn't ready for. So I'll keep that in mind with my future research. Thank you.
Just a quick question. You're not including female athletes. Any reason?
So across most of the leagues, female athletes already have the requirement to wear a full cage when they're playing, from the youth levels all the way up to the professional levels. So that is something we considered as part of the review, but I think more stark contrast in policy pertains to the male athletes.
Very much. Okay, next up we have Dr. Max Stone, who's going to present a case.
Hi, good afternoon, everyone. I'm Max. It's nice to meet people I haven't met yet and those familiar faces. And I want to thank Neil for putting on this conference today. And I'm presenting a case on a rare case of shoulder instability, a reverse HAGL lesion. I want to thank Dr. Fatek, who I don't think she's here today, but she saw the case in clinic with me, and to the athlete who permitted me to use the case today. So this is a 22-year-old linebacker, no prior shoulder injuries. He was playing in an away game, so we were on the sideline, and he went to go dive to attempt an interception, and as he dove towards the ground, he collided with his left shoulder directly into his opponent. Initially, he had some immediate pain, this like non-specific numbness and paresthesias, assessed by the routine physician, placed in a sling, told him to come see us on Monday. 2 days after the game, where he was now mostly troubled by just this painful, severe loss of range of motion. We examined him, and it seemed to be pain-mediated rather than a clear restriction, but we weren't entirely sure given how little range of motion he had in his shoulder. Ordered initial x-rays and ultrasound that were negative, but given how severe it seemed, we decided to order an MRI. Given our exam, we thought, well, maybe we're missing like a shoulder dislocation. He's very muscular. Maybe we're missing the deformity. Maybe there's a fracture or like a very severe bone contusion or significant labral tear. And then with the paresthesias, we were nervous about brachial plexus injury or other nerve injury. So we got our MRI very quickly. And one of the benefits of our program is I happened to be on my MSK RADS rotation at the time, so it was very convenient to be able to pull up the MRI and actually read it like that week with the MSK radiologist. And the MRI showed an avulsion of the inferior glenohumeral ligament from the posterior aspect of the proximal humerus, a reverse HAGL. There are also a few other small findings: strain of the teres minor, at myotendinous junction, some bicep synovitis, a very small slap tear. We weren't specifically suspicious of a HAGL lesion in clinic, but I just want to make a point to say that for these lesions, MR arthrogram is actually the gold standard imaging, where we had a regular MRI at that point. Here's some of the images here. So we have a brief presentation, so very quick review of the anatomy of the shoulder, and then often when we think about the anatomy of the shoulder, we kind of refer to the shoulder as the capsule and then the rotator cuff. But the capsule has multiple ligaments in it, and specifically 3 with kind of 4 groups: the superior glenohumeral, middle glenohumeral ligament, and then the inferior glenohumeral ligament, which has both an anterior and a posterior part, or anterior posterior band. So HAGL lesions, humeral avulsions, glenohumeral ligament, most of them are on the anterior band, 93% of them in fact. Mechanism is usually a traumatic abduction and external rotation movement. Our rare case that we saw was a reverse one, adduction and internal rotation, maybe or likely consistent with it, the way he went to the ground as he attempted his interception. It's most common in active males between the ages of 24 and 26, and they'll be found in about 1 to 2% of patients who have MRIs for pain or instability, like the combination of the anterior and posterior. So the posterior, the reverse, are 7% of that 1 to 2%, and usually in the context of a traumatic shoulder injury. Management is typically managed similar to a labral injury. We sling immobilization, usually up to 4 weeks, and then therapy to improve range of motion and strengthening. And in an athletic population, an operative pair is recommended because of a high rate of recurrence of instability, subluxation or dislocation. Typically, that method will be done by an arthroscopic suture fixation of the ligament. And surgery is quite successful with a less than 4% in the literature recurrence of instability in the operative population compared to 90% in the non-operative population. Of course, this should be considered in a case-by-case basis. So in short, not all instability is labral tears. If you have what you think might be some instability, consider HAGL lesions. The mechanism is key, as I mentioned, abduction and external rotation for anterior and adduction and internal rotation for posterior reverse. The MRI usually shows a J sign, which is there from the image in the ortho, it's in the MR arthrogram, which is the gold standard. And early recognition and surgical repair is very important for athletes to restore stability and ensure a confident return to play. Thank you.
Any questions for Max?
So you surgically managed this individual?
I don't believe he's yet had a surgery, but I think that's the intention.
Good. Going back to non-surgical, but not to offend anyone, but would you think because it's a posterior HAGL that you would put them in like an extra, if you were to sling them, you would sort of sling them in an external rotated position if you thought of that?
He wasn't initially, mostly because we didn't see the mechanism ourselves while we were there, and he was managed by another team while he was away, and we kept him in the position he was in, at least until he got his MRI. By the time he got his MRI, range of motion was starting to return. We had already started the gentle range of motion rehabilitation protocol, but looking back, perhaps, I didn't come across any literature that specifically said to do that, but it does make sense.
So, extrapolating back from the MRI, is there something on physical exam that you can notice afterwards, or is there a test that you can do that you can actually set this up?
Again, it's a pretty rare case, like 7% of 1%, right, for these posterior lesions. But I think for me, at least the teaching or like the learning point was, don't just assume it was sublux. I had a normal X-ray and ultrasound. There was no signs of like even any edema on the ultrasound or the X-ray. It was important to further the imaging, given how restricted his range of motion was. It was clear that there was something wrong. When he came, on basically day 3 post-injury, there's some stiffness that had already set in. It made the physical exam obviously more challenging and had to examine more acutely. But perhaps that there may have been more clues in terms of some testing that would have been able to identify.
What the neurological symptoms you mentioned?
Yeah, so it was kind of, I think he described to us as kind of this non-specific numbness that was kind of radiating from the shoulder down through his hand, but couldn't look at a specific pattern. It was already gone by Monday. But the IGHL, the inferior humeral ligament, runs very close to the axillary nerve. So perhaps some of the injury or some of the swelling could have been pushing or impinging on this kind of my, hypothesis based on what my reading.
Self-resolved.
Yeah, self-resolved by the time he was seeing clinic.
Very quickly, nice presentation, guys.
Thank you.
I think, and maybe Dr. Steinman can clarify, that the MRR sonogram is not nearly as needed when the acute injury happens, because you basically do your autoarthrogram. So maybe in that population, it may not be that much more superior than the standard MRI, if you're lucky enough to get it fast.
Yeah, absolutely, I do. So you see what I saw, because you've got all the natural inflammation that's there, and it highlights exactly what's torn. So it's more in the chronic setting. Once that acute phase is healed, that you would then see that defect by the arthrogram, but otherwise an MR, an earlier MR is going to be better.
I agree.
Thank you so much, Max.
All right, hello everyone. My name is John. I'm one of the sportsman fellows. I'm doing a project today called a Toronto-based diagnostic algorithm to neurogenic thoracic outlet syndrome, supervised by Dr. Michael Catapano, who's a physiatrist based out of Sunnybrook and Sinai, and then Dr. Graham Rochenegg and Oriopolis, who are two vascular surgeons. They run a TOS clinic at Toronto General Hospital once a month. I have no disclosures. So very briefly, what is TOS? TOS is a condition resulting from compression of the neurovascular structures traversing the thoracic outlet. There are three kinds: neurogenic, venous, and arterial. The most common specifically being neurogenic, greater than 90% of them. It's often in patients ages 20 to 50, most commonly in females as well. And the thought process is that there are three main areas of compression. First being at the scaling triangle, the second being this costoclavicular space, and the third being at this pectoralis minor space or the retropectoralis space. Unfortunately, with neurogenic TOS, which is the one I wanted to focus on in my project, there's not a ton of established diagnostic criteria or reference standards for the diagnosis. There's many predisposing anatomical factors listed here that can be predispose you to having this condition. There's a lot of common mechanisms, such as neck trauma, hyperextension injuries, whiplash injuries. And then the population that we see a lot in sports med is these repetitive stress movements, especially among rowers, baseball pitchers. And so what I felt is that neurogenic TOS, because of how difficult it is to diagnose, especially for primary care physicians, would benefit from having some kind of diagnostic primer to guide us, especially in the GTA setting. There's a lot of diagnostic uncertainty that leads to a lot to delayed referrals and unnecessary imaging. The physical exam maneuvers, unfortunately, a lot of the ones we're taught have poor sensitivity and specificity as well. And then it doesn't seem like there is really this standardized diagnostic algorithm tailored to the GTA. So I think, again, a concise evidence-informed diagnostic primer can improve early recognition and really improve referral accuracy. So the primary objective for my study would be to improve primary care physicians' confidence and accuracy in the initial diagnostic workup of suspected NTOS, and to synthesize expert consensus and imaging guidelines into a one-page diagnostic pathway based on this Toronto context, and hopefully facilitate some collaboration between physiatry, vascular surgery, primary care, sports exercise medicine, and then to identify the most evidence-based history and exam maneuvers. So this is just a diagram that was given to us at one of the UTOSM rounds by Dr. Robbie Bowers. He's a physiatrist based out of Emory in Atlanta. What I wanted to highlight in his diagram, and of course this is based out of the States, is that in his diagnostic workup, that red box there, everyone receives an MRI brachial plexus and MRI chest arm protocol, as well as an EMG. So, and I just wanted to know if that is actually possible in Toronto, or if that is really catered to our local context as well. And so I did find, based on my literature search, one consensus statement that has been done, and I'll definitely use this to guide my Toronto-based primer. So this is a consensus statement that was created by this INTOS work group. This included 21 expert hand surgeons just across North America, South America, Europe, and Asia. And they created a lot of recommendations on the workup, the physical exam findings, the history questions that and on how to work up neurogenic TOS. And so I think it'd be helpful to run this by our local experts and see if these apply to our Toronto context, and see kind of how they feel about it. So this is a chart that I made. It's very preliminary so far, and it's just based on my very brief discussions with some of the local experts. So there are two main centers for NTOS right now, one at Toronto General, and then the other one at Michael Garring Hospital / Sunnybrook, because Dr. Catapano works at Sunnybrook. So the one at Toronto General Hospital is the one by Dr. Rochenegg and Dr. Oriopolis. What do they like to have? And I wanted to figure out what they like to have in order to make kind of what warrants a good referral, I guess, is my main question. So what investigations would be required? What are some optional investigations? Is there a role for Botox injections? Do they want to have a child physiotherapy before? Are there any physical exam maneuvers that they prefer? And then what are the main surgical indications? So based on Toronto General Hospital, Dr. Rochenegg told me that EMG and a neurology consult are always done prior to seeing him. He often orders a C-spine and a chest x-ray. And then if he's worried about the more vascular TOSs, then he'll get this venous arterial ultrasound, the venogram, and possibly MRI brachial plexus if he's worried more about nerve compression of brachial plexus. He doesn't do any Botox injections at all, and then they deal with physiotherapists on site. So if he doesn't think that it would be amenable to surgery, they'll do their physiotherapy through there. With regards to physical exam maneuvers, he told me they don't do a ton in their clinic, but they do rely more heavily on the imaging. And then the main surgical indication is really only if there's signs of some kind of like end organ damage. So not necessarily pain, but if they see like significant atrophy. The one at Michael Garry Hospital in Sunnybrook, this is done by Dr. Charles Demestral. He's the surgeon who works there. And then Dr. Catapano does a lot of his injections for him. So Dr. Catapano always gets a C-spine X-ray, chest X-ray, and a dynamic ultrasound to start. He says these are highly recommended. And then he'll go on and do this trial of Botox injection, usually to the scalenes and into the pec space, and see how they do. If it doesn't respond well to that, he'll go on and then work it up further with EMG, MRI, C-spine, MRI, whatever he thinks might verify the diagnosis. Again, this is very preliminary. It's probably going to change as I have more conversations with some of these local experts, but I just wanted to show what I've got so far. And so finally, because I feel like this is more a QI project, I'll probably do one PDSA cycle for the project. So a brief timeline from November to January. I'll do a literature synthesis, stakeholder discussions, consult local experts in physiatry and vascular surgery team. Phase 2, I think I'll do is I'll try to draft this diagnostic primer, disseminate it possibly to some participating physicians. Phase 3, maybe from April to May, consider doing some pre-post surveys on physician confidence, audit some changes in the diagnostic accuracy and appropriateness of imaging, and integrate stakeholder feedback. And then phase 4, the act is hopefully finalized for local dissemination, possibly present at local conferences and explore integration into the MSK curriculum for med school, among others. Thank you very much.
Just out of curiosity, the MRA, is that in like a roots position, or is it just a flat out MRI? Do they put them in any kind of testing position?
I'm not 100% sure for that one. I know that dynamic ultrasound they do put in that hyperextension position, but I'm not entirely sure what the MRI is.
Okay. Well, thank you very much.